have full movement. They'll just have a more obvious deformity, and some of them don't like it. So I will offer them either a manipulation in plaster and hold that for a month, and you should get rather straighter, or get going and have cosmetic abnormality. And mostly they decide to have the plaster. So what am I aiming to do? Am I trying to get this anatomically reduced when I reduce it? They're asleep.
No, you can't.
No, I can't. That's why I can't get it. So how straight do I have to get it? What? As straight as possible, yeah, but I can't get it fully straight, so how straight do I go? So when I tell the plaster technicians, they give it a push, we train them. What do I accept? When the x-ray comes back, what do I accept? How much do I accept?
Better than what it is now.
How much?
Better than what it is now.
Better than, yeah, that's something. You'd be disappointed if it wasn't any better. But that's not really good enough. That isn't a number, is it? I want to be able to measure it so I can know whether it's good enough. So what am I aiming for?
You said 50 degrees.
Sorry?
You said 50 to 70 degrees.
Yeah, no, that's for the metacarpal neck fracture. I think if you have 50 degrees here, you get a big deformity.
About 20 degrees.
What?
20 degrees.
Yeah, I think you should be able to get less than 10. So I'm prepared to accept that, but the evidence suggests 10 is fine. But you need a number. So that when you send them round, you get a check x-ray and they come back and they're at 15, what do? Well, I'll tell you what you do. If it's 20 past 2 in the afternoon clinic, and you're not quite sure, you ask the boss. And if it's 20 past 5, you go, that will do, okay? Right? Don't you? That's what happens. So have you read Kahneman's book, Thinking Fast and Thinking Slow? Okay? So if you remember nothing else, and you probably will remember this is worth remembering. So this is a lovely piece of research they did in the Israeli parole board. They did it there because this side is people who have taken the exam in the next 2 years, and over there is people taking it later. So if you're not in the right place, move. Okay? So the Israeli parole board, and they did it there because one of them was Israeli, the other was Jewish. They were doing it there, but it was applied everywhere else. You go for parole. So these people who might be suitable for parole, they go in at 9 o'clock. Your chance of parole were 90%. By the end of the morning, 12:30, your chance of parole are about 10%. Okay? Come after lunch, waking up, it's round up to about 70%. By late afternoon, it's down to virtually nil. Okay? Simply because people get tired, they don't like making difficult decisions. We've all been there. That'll do. Oh, you'll be all right. See you in a week. Okay, and you need to know you will do that because you are human, just like these judges. And therefore, at 5 o'clock in the evening, I know my decision making is less good. And I will go, I'm just too tired to make a decision properly. So I find ways around it, or I'm more disciplined than I do it, or ask someone's help. But you will do that. And that's why you've got to define it, not go, it'll be all right. So you get hopefully straighter. Okay, and here you are. It's not easily shown, but that's straighter. And leave them in plaster for a month, get them going. They should be very nice. Something like that. So they've got reasonable movement in the fingers. But, and this is important, and this is where people get caught out, because you see a fracture like this, and you'll find that's very difficult to reduce. And then you think, well, I went to this guy's lecture, he said you didn't need to operate. You need, this is, you know, this way you need to operate. He's a moron. I'm going to ignore everything he said. Now, I may be a moron, and you may choose to ignore everything I said. That's entirely up to you. I'm very relaxed about that. But this is an important concept, okay? Just sometimes with these, there's something different. And the trouble is, it's easy to remember the one exception and then think, well, that applies to everything, so I've got to operate on everything. The problem with these off-ended fractures, and you can see that's off-ended here, right? They can be difficult. Sometimes you can get them back. It's worth a pull, but often you can't. And those, I think, do sufficiently badly that I would offer the patient surgery. How you do it varies. You can open and plate it. I'd probably manipulate it and wire it. But sometimes you will need to do something. For the vast majority, you won't. And so this is where we get subset bias. It's a very important concept. You'll hear lots more about this in your career. Subset bias, where we get biased by a subset of the injuries, and therefore we assume all of them are like it. That's quite obvious. There are other areas which are more subtle, and you need to work out, and you'll get better in your careers are working out subsets of injuries that we've lumped together because you'll learn more and people will make new findings. So be aware of the subset bias that may skew you to think something needs treatment when it doesn't, or vice versa. Spiral long oblique fractures, one of my favourite injuries. So Alcatown wrote about it, but we wrote about it in the series in Bath. They will follow up for over 6 months. Essentially, similar outcomes, but more complications with surgery. And you just don't need to do anything with these. So here's a classic spiral fracture. And even if they present with malrotation, they derotate. And the reason is the intermetacarpal ligaments. So if you am a metacarpal here, this is the head, funnily enough, okay? As you move it, it shortens, and then those ligaments will tighten the fracture, okay, and derotate it based on the other ones. And they limit the amount of shortening. So this is shortened by, say, 3 or 4 millimeters. And we know that you can shorten your metacarpals by at least 5 millimeters without any big problems. So spiral metacarpal fractures, what I do is I get them in clinic, I get them to make a fist, and send them into the room. I say, get there under the warm water and make a fist. When you can make a fist, you can go. Do you know, no one ever goes, oh, I can't say that to me, doctor. Some of them say, I can't make a fist. And I go, well, you can try. And then I say, you can't make a fist, we've got beds here. The only reason we have beds in the hand clinic is for people who stay in the night because they can't make a fist. And most of them accept that. So they make a fist and then they go. So here's another one, okay? And this patient came to clinic, this was at 1 week, and that was their range of motion. Slight drop knuckle, you see that knuckle slightly shorter, that's all. Marginal shortening, excellent range of motion, discharge. Don't fix them. Commonest complication if you fix them is malrotation. It's very easy. You don't put them in plaster, that's really a waste of time, unless they're very sore and you might give them a splint. Spiral metacarpal, long oblique, just mobilize, they do really well. Avulsion fractures. Now these are common and people worry about them and mostly they shouldn't. And again, having said that everything in the hand deals with bone, these sometimes don't, but you don't need to worry. So fingers, so collateral ligaments, David Shearing wrote about this, and he said for finger collateral ligament injury, so I'll just show you what that is. That's this sort of injury, a pull off from here, often more displaced than that. He said that all of them need surgery because of the risk of non-union. So he x-rayed them at about 6 weeks. Most of them had pain. It didn't look like they were healing, so he fixed them. We did a study in Nitin's Sawankas, I think it's in Gloucester, isn't it? And we showed that none of them needed surgery. That's great, isn't it? Marvellous. There we are, wonderful science. Two supposed leading authorities with completely opposite views. And it's to do with what you're treating. So we would strap them for 4 to 6 weeks and get them going, and they were fine. As long as you don't x-ray, you don't have to worry. One of them had some pain, we injected him and that settled. Now, when I did this study, we strapped them for 4 to 6 weeks. Now, I'd probably strap them for barely 2 weeks. I suspect you don't even need to do that. So this is not an injury you need to operate on. They do fine. Thumb collateral ligament injuries, you'll see many more of these, and there are a lot of papers on this. And many of them report really good operation results with surgery, because most people do well with surgery, however much you point it out. And quite a lot of them report high incidence of non-union, up to 60%. But the great thing is, it doesn't matter. Because if you look at the outcomes, you do nothing, or some immobilization but no surgery, they do just as well. So try not to operate. Something like that, you think, gosh, that's well displaced. The fragment is, but the soft tissues won't be. And the only thing we need to worry about is a stena lesion. You all know what the stena lesion is? Can I have a little bit more movement, show you're still awake? Not just you've got your eyes open, we know this. And though you can get a bony fragment in the stena lesion, it has been reported in the case report, that is real subset bias. That will heal fine. That will be stable. I tend to immobilize them in plaster for 3 or 4 weeks just to make sure, and it puts them across to really help the soft tissue settle. Whether that's even necessary, I don't know. But you don't need to operate. And here, radial collateral ligament injury, even with a bit of displacement, this is a concave joint. Concave joints are tolerant of malunion. Okay, you know that, you see that in the distal radius, you see it in the tibial plateau. They're relatively tolerant, whereas convex joints are less so. So they do fine. And again, I'd probably just immobilize them. And something like that. So there are lots of these injuries. When I take the x-ray, I'm hoping to see a bony injury. Because when I see a bony injury, I'm relaxed. They're going to do fine. When I don't see a bit of bone, I'm worried about instability. Probably a lot of those I'm going to fix. Phalangeal fractures. Long oblique, spiral transverse. Mostly there's no science, there's just belief. So here's a long oblique, and I've done that before, and that works nicely. But I suspect you don't need to. This is a lady I treated and just left it, slight shortening, reasonable alignment. I saw her about 6 or 8 years later for a completely different injury, and that's her range of motion. So I think mostly we don't need to treat those, but there's no science behind them. I think these are difficult, the base of proximal phalanx fractures. We'll discuss this a bit more. I think a lot of these can do well with immobilization and reduction. You don't always get a reduction like that, sadly. And something here, this is a spiral fracture, and you can see that, you see that line going down there. It's a spiral fracture. In fact, David recently showed me a nice technique where you can get a wire up there, which I haven't done yet. But I think that a lot of time you can strap those. And penile fractures of the MP joint is of particular interest to me. If you see any of these, I'd be grateful if you could let me know, because I'd be interested in seeing a long-term outcome. I think it's a pretty forgiving joint, and I suspect we don't need to do anything, but some people do. And that's the sort of thing people do, and I suspect it was unnecessary. So PIP joint injuries. Now this is another particular area of interest. We've done some new work. This is cutting edge stuff. And it's based on the difference between convex and concave injuries. So convex injuries, typically condylar or unicondylar fractures, in adults in particular, once they start to move, they often move more. And David Shearing has done good work on this and shown they do well with surgery. So I'm expecting to operate on the condylar fractures. Not always, if it's a millimetre, I might watch it and so on. But the concave fracture dislocation and penile fractures, I'm expecting not to operate. And I'm going to come, and it's all to do with pivoting and gliding, which I'm going to come back to, but I'm going to prove it here, because we've not proven it there. So bony mallet injuries, you'll have seen these, and it used to be written that if the fracture fragment was more than 1/3, you needed to operate because they were sublux. So this sort of thing, here's a fracture fragment of about 40%, and the worry was that that would fall off the front because it was no longer constrained. So people would do it, and there are all sorts of clever K-wire configurations or screws or all sorts of things for that. And your worry was you'd get that. So that was a medical student from Oxford, treated there about 15 years ago. They got that one wrong. That's not salvageable. It's rare, fortunately. But what I noticed was, if you put them in a mallet splint, you always put them in an extension. So we developed an extension stress test. We've written this up. So if you push it into extension, here it is, and pushed into extension, and you see that this one has pivoted about that point. Can you all see that? Okay, so this is pivoting. And we separated it out when we looked at them, and I'll show them. Pivoting had a high risk of subluxation. If they glide, it's a very low risk, and you can largely be fine. If it tilts, it's not quite clear what that is, but it's probably more like gliding. So here, that's pivoting. Here, similar thing, but that's gliding. And this is a fracture fragment of well over 50%, but that is remaining congruent when you stress it into extension. You can all see that? And this one, another big fragment, and we put that into extension, and it's sort of more gliding than pivoting, but it's not quite perfectly either, so I call that tilting, and I'm not quite sure what that means. So now, with these, I don't measure the size of the fragment, though some recent work that came out at the same time as I published on this suggested that about 50% you almost never needed to do anything. But the key is, when you stress it, does it pivot or does it glide? Because this is not an avulsion injury. This is a impaction extension injury. Okay, so you fall like that and you knock it off the back. And I can't explain now why it's not an avulsion injury. We can talk about that later. So you don't want to be putting it too extended. If anything, you want to put it in very slight flexion. But if you do your stress test and it glides, they will be fine. If they pivot, they don't all need fixing, but I watch them carefully, and they can drift over 3 weeks. And if they are subluxing more than 1 to 2 millimeters, then I will reduce and wire them. But most of them don't. So even more of these now don't need surgery. And again, that's subset bias. So people have been looking at the wrong subsets. They've been looking at the subset of fracture fragment size and thinking you need to fix them because some of them do fall off. They've not worked out why. And it's probably related to the soft tissue damage in conjunction with the fracture fragment. So back to PIP joint injuries. So a lot of things have been said about PIP joint injuries. I'm telling you, concave injuries are more tolerant of malunion. And when you think about that in the cold, hard light of day, you'll realize that. And it applies to, I think, almost all the joints we treat. Broadening of the base of the middle phalanx on the lateral x-ray doesn't matter. So some people treat this to stop the broadening, but I think there's no evidence it makes any difference. And I still think it's pivoting versus gliding. So this is my new hobby horse that I ride around with Gail Bennett. So here, this is a pilon fracture, not too displaced. This bit has been pushed up, but that's not looking too bad. And he was able to mobilize quickly and you get going. And one of the keys with these is you've got to look for the DIP joint as well as the PIP joint. Because whatever you do, whatever fixation you do, you'll step on the DIP joint, which reduces their range of motion. So we report on the PIP joint injuries, the PIP joint range, but the DIP joint matters. So this is the sort of one I've now treated. Here's, you see the subluxation, over 50%, it's back. 5 years ago, I'd have said that definitely needs fixing, various ways of doing it. Now I get a lateral flexion x-ray. And here, this was at about 10 days. You see that's coming round. That's reasonably congruent. It's not perfect, but I think that's gliding enough. And here he is at 6 weeks. He's still sitting out the back, but this is his range of motion. So he's virtually straight. He's flexing to over 100 degrees. He's got good DIP movement. I can't do better surgically. I don't think he's going to get long-term symptomatic degenerative arthritis. I think he's much better moving than not. Now, this is really pushing it right out to the limit. And my risk is that I am too much of a zealot and I over-push my beliefs and I then actually harm some patients. There's a risk of that. But if you get lateral flexion x-rays and look for gliding, then those patients just mobilize early. I keep a close eye on them, but they don't need surgery. So Bennett's fractures. Okay, so who of you have been taught that Bennett fractures almost always need fixation? And that's the standard treatment. That's been the standard treatment in hand surgery for 15 years, maybe more, maybe 20 years. Okay, but we looked at this, and when I say we, I mean Gray Edwards did most of the work. That's how it goes. And so it's been widely reported surgery is needed, non-operative treatment gives high rates of malunion and OA. And one of the things you need to do in your career is be skeptical about what people say if the studies haven't really been analysed in detail. So you see this sort of fracture, and you think, yeah, that's going to need fixing. But we did this systematic review, which we published. A lot of studies were looked at. A lot of publications, some of the ones from the 50s were the best. They're all retrospective, and there was a large range of different treatments. So we looked at pain, nearly 700 patients. 23% treated operatively had pain. This was at 4 years, 33% at 12 years. It was greater, but that's not a very high number. And quite a lot of these had almost no treatment. They didn't have period of fast. They had just immobilise. So you'd expect them not to do necessarily so well. If you looked at return to work, almost all returned to work, whatever treatment they had. Look at osteoarthritis, they had a third of them had osteoarthritis, even at the longer treatment for the non-operative one. So surgery doesn't prevent your osteoarthritis. And you looked at complications, well, non-operative treatment, almost none. A reasonable number of complications, and these are from the good series, and you can imagine they're worse than others. So really, the data doesn't show that you do better with operative than non-operative treatment. Now, that doesn't mean you do nothing. I think you need to reduce these and try to hold them reduced, and you can't always do that non-operatively in my experience. And then they need operation, but if you can, then that's what you should do. So we developed this plaster and bath. It's a two-stage plaster. You flex the MP joint down, and then you push against that and reduce it. And you see that the MP joint normally extends again, but with pressure here, that's a nice reduction, and that patient should do well. So it's worth trying at non-operative treatment, but it also shows an awful lot of what we've been taught historically is not true based on misrepresentation of data. So in conclusion, most fractures in the hand don't need surgery. And you need to know that, because if you start operating on people who would do well with non-operative treatment and it goes wrong, you're going to struggle to defend that in the court of law, public opinion, and all the rest. This you should be asking for every condition you treat, and certainly hand fractures. Can you reliably improve on the natural history? Part of the problem is sometimes we don't know the natural history. Sometimes we're guessing, but there's an awful lot of belief that we fix it and then they do so much better, and if we don't, they get terrible arthritis. But we don't see lots of people with terrible arthritis who had very different treatments 30 years ago. Non-operative treatment is not nothing. It does involve careful follow-up, and if you don't like doing that, you won't do it well. Maybe you should fix more fractures, or you should be in a different branch. You need to know the literature. You can't know it all, but you need to have a reasonable sense of what's going on. I published a paper on this. It's in the German Hand Surgery 2015. You might want to read that sometime. But do remember that there will be subset bias. You will see injuries, and you think, well, he said none of these need treatment. I'm sure this does. Yeah, there will be exceptions. There will be the odd case. But for most of these, most of the time they don't, and that should be your default. And this is a really important question you should ask yourself in a lot of medicine, a lot of surgery, especially in orthopedics. How many people need to be a bit better for the small percent who are ruined by surgery? And I think that there are a lot of people who strongly regret ever having met their orthopedic surgeon, including me. Thank you very much. Any questions?
You said the two-stage plaster for bends, so you mean the two-stage reduction?
Well, yes. So what we do is we put a little plaster to hold the MP joint. The problem is, if you just put a standard plaster on, you tend to press on your base of proximal phalanx, and in many people that will hyperextend. It doesn't hyperextend in me because I'm a stiff Anglo-Saxon, but in many people it will, and then that flexes the metacarpal head, so you're not actually really reducing this. So that gives you something to press against, and we think that helps do it better. So you need to press here, but you need something pressing against that. So that's why we do that. You put this on, let that go hard, maybe 10 minutes, and then press again.
So,
Yeah.
what do you do for the extra-articular proximal phalanx transverse fracture that's flexed up?
Extend it out, base of proximal phalanx. I tried a range of things, and I don't know what the correct answer is, and it's part of the NIHR grant that's been put in by the Nottingham Union. I think they're at the second stage of that. So I think that it's very arguable, and I think you can do almost anything and justify it. So the elderly tend to mobilize them. I'm more worried by stiffness, and I accept some malunion. Younger patients, I try to strap them down. I've tried plasters. Some people use posi splints. I've done Belsky wiring. I tend not to do too much and try to keep a close eye on them, but they don't always do well. I think it's an unsolved injury at the moment.
When you say you're keeping a close eye on them, are there specific things you're looking forward to, or is it just to make sure that they, like the ones that you're getting moving, or you're asking to try and get moving, to make sure that they are moving, or are there other things that you're looking at?
Yeah, I think it depends on the injury. So something I'm expecting to do well, this will do with expectation. So spiral metacarpal or metacarpal neck fractures, I'm expecting them to do well. Once I've shown them that they can make a fist, I'm not going to follow them up because they can make a fist today. They should be able to carry on making it. There shouldn't be a problem. Something like a PIP joint injury where I'm worried that they might get stiff and not do well, or I'm worried that although they seem to be gliding initially, it might move, then I'm going to keep a very close eye for 2 or 3 weeks, expect them to make reasonable progress, maybe look at their x-rays. But I've got a sense of how they're doing, a sense of where I'm expecting them to get. And normally by about 3 weeks, if they've got an injury that they're going to cope with, the body's going to cope with, they should be getting pretty good range of motion. So I would be expecting 50 or 60 degrees of flexion at the PIP joint, at least some good DIP joint movement, not too much pain. Some of that I think is hard to define, and some of it's just a matter of I've seen a lot of people and you can read it and you just get a sense, actually that looks swollen, they're just not moving it, they're anxious, and then you might have to change or be more interventionist or get more therapy. So it's not an easy one to answer.
Regarding the return to work, does their occupation affect sometimes whether you would operate on them non-operative in terms of builders, etc.?
I think that's a very reasonable question. I think in the main, no, because I'm not sure we can make a vast difference for most people. But I suspect yes, and it may be that for some sportsmen, you might fix them to get them back early. And, Beckham had his skateboard fixed, didn't he, by Doug Campbell to get him back early. So there may be a role for that. I think for most things, probably it doesn't prove it. I mean, what was it? The Australians reported, I think, on spiral non-oblique metacarpal fractures and said if you fix them, you can get them back to Australian rules with a splint in 2 weeks. And I thought I'd write in, but I decided it probably wouldn't make a difference. And I'd go, well, 1 week you've got full movement. If you play Australian rules, you don't have any pain fibers, so why would you play tomorrow? So you've wasted a week by having an operation.
To get the hyperextension views, do you get the patient just to extend?
Yeah, well, yes. Now, when I say yes, I tell the patient what they need to do when they go around. Exactly what the radiographers do, I think it varies. Sometimes they'll get the patient to press, sometimes I'll get a pen to press, sometimes I'll get a lead hand to press. I just want them to extend it. So I think you could do that in many different ways, but I make sure the patient understands where they go around. And sometimes they'll come around with virtually no extension on the x-ray, so I send them back to do it properly. Jolly good. Alex, I think you're going to entertain us now.
So are we going to do these MCQs?
Yeah.
Should we do them first? Have people seen them before? Is that how it works? Or it's all a
No,
surprise?
they haven't. No, surprise. Yeah.
Oh, sure you can't contain your excitement. Who's written them? Who's put them together?
Andy did this
And
week.
he's not here.
He's not. No.
Oh, that's a wise move. I've seen the questions. He'd be having a difficult time, I think, as we went through them, but he's now away. So, have you got them there?
I can put them up. Yeah.
And then we can go through them. So all of you guys over here have got the exam coming up soon, have you? Who's got the MCQs in November? Good luck. You guys over here can relax for a moment. Don't worry, your time will come. I could read them out to you, but I'm confident everyone in the room can read. If you've got this far without being able to read, in itself that's a talent, I think. So do you want to show them the pictures and then we can go back to the options? I mean, this is a nice common topic they picked for the question number 1, haven't they? Pisiform non-union. So who wants to plump for what they go for? Who go for A? Or 1 even? No one wants 1? I'm not even sure I do a scaphoid ligament repair when you've got a scaphoid ligament problem, so I don't know how that gets in there at all. 2? 3? So people want excision. Who's seen excision of the pisiform in their life? Seen that? You put your hand up, Graham. I'm assuming, Adam, you put it up because you were sitting next to him when he was doing it. Probably nodding your head going, my word, this is what's going on here. I've done it once. I have done it once. But not for a fracture. So who wants to do, well, 4's not, doesn't count, does it? Because it's a different bone. But no, who wants to fix 5? You want to fix it? Has anyone seen that? I sort of read that and I thought I'd quite like to have a go. I mean, the answer that's been put is 3. I mean, if you're talking about MCQ technique, then I can see why they've done that, because really it's 3 and 5 are your 2 options, neither of which are very good. I mean, the proper option is just keep sending them away, isn't it? You'll be all right, you'll be all right. And then if you're at your level, then 6 months passes and then it's someone else's problem, isn't it? I mean, I think it does in the explanation, except that pisiform injuries are very, very rare.
I don't think there's any evidence for cast immobilization. I mean, I think it's, first of all, you won't see it. If you do, it's because you've got a CT scan, and by the time you've got it, it'll be well past the sell-by date. And why wouldn't you wait at least a year? For everything in the hand, wait at least a year, unless you're fixing it in the first few weeks. So.
Show us the pictures there, we can come back to the options. So what are we seeing? Go back to what are we seeing? How are you going to describe that? So what are we going for? Slap wrist. We can't see that the scaphoid's fractured on these views, so it's a slap wrist, isn't it? And what grade are you going to give that?
3.
3, based on what? Why have you said 3?
Arthritis between the lunate and the
Lunate and the
capsule.
Okay. And then other people would say that's sinking of the capitate, isn't it? Depending on how you want to refer to it. So it is a grade 3. So then if we go back to what our options are, then you've got to go to your menu, haven't you? And go, what do you do for a grade 3? What are your options for a grade 3? So who thinks the option for a grade 3 is number 1? Okay. So the professor's put his hand up, so that might have drawn some of you along. But don't be fooled. He's already told you that lots of his decision making is flawed because he's a zealot about non-intervention. But I mean, I'm inclined to agree that it's a reasonable thing to do. But I think if you're thinking MCQ for the exam, that is not going to be your answer, because that is not the sort of textbook operation for a grade 3. It's a textbook operation for grade 1. So number 1. but it is an entirely reasonable procedure to do. And actually, a lot of people would advocate that as the first option. What about 2? No one wants to do 2. I know I can compensate only so much.
It's a recognised operation.
It is.
It's a recognised. I wouldn't do it. It's a recognised operation for this procedure.
3. Says in the question, we want to preserve it.
Good. You've almost shown that you're paying attention, Mark, which is a shock to me more than anyone, I think. So that's important, isn't it? It's telling you that, isn't it? It's giving you the clues. Because so many of these MCQs, all the answers are acceptable. So I think you've got to exclude 3 on the basis that it's asked you to preserve movement. What about 4? So if we go back to the original picture, I think you can exclude 4 on the basis of that. I have to say, as I have gone on, I'm not sure I would exclude it on the basis of that, and I probably would do a PRC because it's a more straightforward and predictable procedure, I think, with less complications. But textbook, MCQ answer, that's got wear and tear, so you shouldn't be doing it.
Would you do an MR or a risk scope?
But, so what we can say is yes, but that's not the answer if we're thinking MCQ.
I mean, I would also say, I think for this sort of thing, you consent them for both and you decide at the operation. I think that's the only way. The X-ray doesn't tell you enough. You'll be deceived by the MRI. You look and you then make a decision. And then you do the PRC.
And who wants to do 5? So I think 5 feels like it would be the right answer for this question, accepting that all options have some merit. And they've done this, they then got put there, haven't they, the classic textbook, this is your menu for what you do for slack wrists.
I mean, what I would say is, for this guy, I'd be expecting not to operate. I'd be expecting him to jolly him along, steroid injections, splint, wait a bit, probably settle down, probably never need surgery. Wouldn't you think? 65?
Yeah, I think so, yeah. It is just the artificial nature of these questions.
Yeah, absolutely.
Next one. So what's the answer to this one? So I didn't quite hear that, you all shouted at once. I'm going to have to press you now. Who wants to go for 1? 2? 3? Lone hand went up, came down quite quickly. Stuck to his guns now. 4? And 5. What's the answer, Roper? I think everybody in the room should know the position that you should be splinting your hand in when you're seeing all these different types of hand injuries just to protect them. A lot of people refer to that as the Edinburgh position, don't they? I'm guilty of that, although we shouldn't really be using these eponymous names. And if you don't, in theory, you get flexion at the PIP joints.
You like Chip James, who was the professor in Edinburgh, who was not a gentleman. He insisted that everyone in a plaster had X-rays in the plaster to make sure it wasn't the Edinburgh position. But you can't ever achieve that. So one of the registrars put a bit of a plaster on and took the X-ray like that, and that was the one they showed you.
Every time.
Kept him happy.
We've got one of them for pivot gliding and tilting. So, proximal phalanx fracture. You've already had a conversation about them today, and you're worried because nothing says just plaster immobilisation or get going quickly. Oh, shit, where are we going with this? So you can show the picture to everyone. So everyone's seen that. We've only got one plane, we haven't got the other. So it's difficult to know how displaced it is in the other plane. It doesn't look too bad, doesn't look like there's any rotation. So now we go back to our options, and none of them say conservative. So we've got to go through that. You've got to work out, haven't you, what's completely not acceptable. Do you want to do an open reduction through the metacarpal head? Do you want to put a straight plate applied dorsally on the extensor tendon? Lag screw it, 1.3mm screws, radial approach. Placement of a condylar plate. And then a retrograde passage of 2 1mm K-wires through the PIP joint. So really it's about picking the best of a bad lot, isn't it? And 3 is probably the best of a bad lot, although still, that's, you know. I like the explanation.
Can you just put that back up, the X-ray? I mean, my feeling, I look at that and I'm thinking, that's going to heal fine. It heals in that position, should do fine. And I'm thinking, you go and fix that, anything slightly goes wrong, and people are going to go, well, hang on, why did you fix it? That was going to heal fine. So I think that you set yourself up into a hiding to nothing when you fix these fractures. That's the problem, particularly in this, Montgomery age.
Do you think that plastic surgeons are more restrictive to these?
What you have to remember, and I don't mind saying this to any plastic surgeon here, they have a surgical solution to everything. So what is the solution to Brexit? There is an operation if you're a plastic surgeon. How do you solve the nightmare in Syria? There is an operation. That's all you have to know. They have a surgical solution for every single problem that they will ever be presented. And if they're not proper plastic surgeons. So yes, they would, I'm sure, fix these. And we see them every so often.
How would you immobilise it? Or would you let them go?
I would just worry that would displace, and I'm probably being a bit wet. So I would probably put some sort of radial, I think it's the index finger, so radial gutter, plaster or splint for 2 or 3 weeks. But if they were really comfortable and sensible, I might be tempted just to let them gently get going, take it really slow, watch them weekly for a couple of weeks, and go from there. And I think if they can move quite a lot early, they're either mad, which there's probably not much you can do about, or the fracture is pretty stable, the body's quite tolerant, and then they're going to be fine. So I'd probably be cautious, except if I really thought the patient was very clear and would understand and happy to take the risks and so on.
Who wants to go for 1? 2? 3? 4?
Just one.
Sorry?
Excellent.
You want to go for 1 now?
Yeah.
Okay. 5, and I want to go for 5? I think this is quite a difficult question because it does depend on which paper you read, and there is mixed evidence, isn't there? Sorry? Well, but Swift hasn't shown anything, it hasn't actually been published, so be careful about mentioning Swift, because lots of people come to me and say, oh, Swift says this and Swift says that, but we haven't had any firm data on Swift. With people who made comments said there's probably not much difference in the early outcomes, but it's not published.
It's presented the way.
Yes, okay, presented.
Yeah, but they haven't released the
So
data.
just be
The
careful.
data's not been approved and released yet. And I know that because I spoke to Joe recently.
If I was answering that question, I think the answer's got to be probably 4, because I think there is evidence out there that it can speed your fracture healing up. But that's about it. But I don't know what answer, I've forgotten which answer it was. I thought this was quite a, there you go. I thought it was quite a challenging question, but then this is what the MCQs are like. Is they start picking this stuff up.
But you see, that's difficult because Tim Davis has shown that CT scan at 4 weeks shows evidence, you can tell whether it's going to unite by the evidence of bone healing at 4 week CT scan with a minimally spaced fracture. So it depends where they got that evidence.
Well, this is probably going back to the earlier work, isn't it? So you've got the problem with these MCQs is some of them are outdated. Show us the next one. I'm not sure that's the greatest question in the world. This is a gift. Should we be hesitating with this one? What's this one? Oh, we have a little bit of hesitation there, shall we? Not to rush into it.
They're on the 6T, they're looking at the water and they're a bit worried. They're not sure whether they'll clear it.
What lies on the older side of the median nerve?
This is the radial side of the median, isn't it?
Sorry.
Well, come on, chaps, help us out. I mean, it's going to be a long afternoon. He's got a lot more difficult questions to ask you.
One.
View. No one's allowed to say you want to know whether it's going to pivot, glide or tilt. There is not an option for that.
But I'll tell you what it will do if you ask the question.
Who wants to go for 1? Does anyone want to go for anything other than 1? I think that's pretty straightforward. That you think with those options that 1's got to
And
be
that,
the
if
best
you
one.
did send that, that would pivot. That would not glide. But I don't think it's necessary to do that. You know, it's well subluxed. If you leave it like that, that's not going to do well.
Next one. Yeah, so let's confirm that. I thought this was quite difficult. I wasn't sure I was 100% certain when I looked at this question that I would know that I was sure I knew the answer. Who wants to go for 1? 2? 3? 4? 5? A large proportion of people have chosen not to answer this. We're not running a negative marking system on this occasion. You're protecting yourself. I thought 3 was the answer when I did it.
Yeah, I would go for 3. I'm not
I mean,
sure.
it is the correct answer, but I have to say I wasn't 100% certain. It's been a while since I've looked at that stuff.
I would say the big new move, I would think, in flex tendon repair is doing more multi-strand repairs, minimum of 4 strand, and worrying less about the pulleys. leaving them more and more open. I think if they catch on the pulleys of Burnley, I must say I expect to certainly divide the A4 pulley if it's anything up around there. Around here, I'd be relaxed about dividing the A2. They say you don't get bowstringing. Of course, that's nonsense. You always get bowstring. It just doesn't really matter in the vast majority. And you're better at getting the glide.
Should we have a look at what we're dealing with? So what's the injury? So what's the treatment? I think that would seem the sensible question, wouldn't sorry, the answer. Once it's there, I don't think you can not do that.
Would you do a carpal tunnel decompression because he's had symptoms, or would you always do a carpal tunnel decompression?
So the answer to that for me would be depending on how quickly you can get someone who knows what they're doing it. So if you think that someone in the morning, if they've got dense paresthesia, then you've probably got to do it. If you think it's going to resolve once you take the pressure off and someone sensible is going to get at it the next day, I wouldn't. I'd rather you didn't stick your knife anywhere near somewhere where I've been or I'm going to go.
Yeah, I would agree.
You have to make that call. I mean, in theory, if you reduce it, you should take the pressure off the nerve.
Most of them, I think, get some paresthesia, and you reduce it, and the paresthesia is less, but a bit. But unless it's very dense, I'd probably leave it.
If they turn up late, a few days late, because sometimes they get missed by any.
Well, if they turn up late, then you're going to send it to the person definitive straight away. And then they can make that decision, and yeah, you probably would. If they turned up 2 or 3 days late and they've got medium nerve symptoms, you're going to do a decompression.
But I would still try and reduce it on the day. Yeah. You'd be surprised, sometimes they will get back, and that just helps everything.
Even after 48,
yeah.
72 hours.
Yeah, you can have a try. Doesn't work. You know, you're not really lost. You can just do that in local in A&E. Enough local anaesthetic around. You should be able to get them comfortable enough and put them in traction for a while, and hopefully it'll go back. And if it doesn't, well, you try.
You shone on the last anatomy question, so I'm confident this will be equally as easy. What are you going for?
5.
5. It's quite easy, that question, because 4 doesn't exist, and 4 is the only one when you start off and you think that could be the other answer until you work out that I just assumed that Mr. James had missed off brevis off the end of the answer. Maybe I was being a bit cynical, because that 4 makes no sense otherwise. Right, I think we might leave it there otherwise, because we've got, is that it anyway? What are the chances? So what I've got is some slides, rather than just go through and give you lots of information, just to get people justifying their answers. We've heard, yeah.
And I think we're going to have the X-ray interpretation on this side and the treatment on that, aren't we?
So what I want to
around people, then you're going to start answering.
The message I want to try and get across is that there is no right or wrong answer to most of these questions. What you need to get into the habit, particularly these people this side, is justifying what you're doing.
Yeah, so if you take an exam in the next 2 years, you're on that side. If you're not, you're on this side. No one wants to come down. You find the air is quite thin up there, and it would make you think less quickly. Or Maybe it
So
won't.
what I want to try and get across to you is that you've got to give your justification for the answer
You
you
come down further, it says safe down here.
just. But there's lots of ways to skin a cat, and so there isn't necessarily.
Have you ever skinned a cat?
I'm not going to admit that in public. So just as a little, I don't want to make this too painful for you, so I thought if I tell you it's going to be a distal radius that you're going to look at, you'll feel more confident about describing it. Being it took so long to get to FCR, I'm pleased I put that in. So, well volunteered. What do you see? No marks for distal radius.
There is a APM astral paint film radiograph of the left wrist showing a dorsally displaced distal radius fracture,
Why is it displaced?
dorsally angulated.
Why is it angulated? Justify that statement.
The distal fragment is angulated dorsally.
Okay. So what's normal?
It's a slight volar tilt.
Slight volar tilt. So our orthopaedic surgeons renowned for a specialty where slight is important. We like things to be precise. Because this is what the exam's all about. So what is normal on the lateral film?
10 degrees of
Okay. I'd be slightly more convinced if you not sort of frowned as you thought, pick the number out of your head, looking at your own radius like it was going to help.
There are some more poor prognostic features in this case, such as there's an element of dorsal comminution, there's loss of radial height, radial inclination, and there's positive ulnar variance. I think there may also be an intra-articular split as well. So.
Okay, it is important. This is a distal radius. Everyone thinks they know how to manage a distal radius. The only people who probably know they don't know how to manage it is the two of us at the front. Because these are difficult injuries. And you've got to be precise about how you describe them. There is very clear parameters to say that it's displaced or it's not displaced. That is what they're going to expect in the exam, is you to say that the inclination, what's normal radial inclination?
22 degrees.
Okay, so you know it, so you've got to say that's why it's gone, and you've got to be prepared to measure it. You guys are coming soon. I've got to be able to say this is how I'm going to measure a radial inclination. So we've had it described as a displaced distal radial fracture. How do you want to manage it, Mr. Smith?
So I'll begin by reduce the closed reduction initially and put it to a plaster, normal plaster, get a check X-ray plaster, see what the positions are.
Okay. Is there anything that's going to influence your decision?
On the check X-ray or on the initial one?
On your initial management?
Okay, so I want to know if it's an open injury, is it core history, whether it's an isolated injury, check the neovascular attack.
Okay.
If that was the case, I would proceed with reducing it closed.
Okay. And then how are you going to, what sort of plaster are you going to put on it?
So if I'm seeing this patient initially, I'll put a back slab, put the patient into a back slab and try and mold the back slab the best I could.
In what position?
In a neutral position, but with a well-molded plaster in a neutral position.
Not flexion.
Not flexion, yeah.
Okay. And then what are you going to do?
Get check X-ray and see if it's reduced.
So you're happy it's reduced?
So if it's reduced into a good position and I'm happy that the plaster is well fitting, then I would see them again in a week's time and get further X-ray in clinic.
Okay.
But I warn the patient that there's a high chance of the fracture displacing if it's an unstable injury.
So why is it unstable?
Well, it's clearly had a significant force go through it. It's got some dorsal comminution that we talked about, and then maybe a slight intra-articular element you can see on the lateral view. So there's a risk that dorsally that might slip back into that position that's it's lost that posterior support.
There's a really good paper, LaFontaine Injury, 1989. It's an excellent paper for describing the risks of displacement of a distal radial fracture and the 6 parameters that you should be looking at. I think that's quite useful to spurt out in an exam when someone starts saying to you, is it unstable or not? It's better than, could be that, could be this. So this, come on then, come and describe this one. Don't just say it's a displaced distal radial fracture, otherwise I feel we've learned nothing.
Okay, so it is that, but this one. Again, dorsally angulated has lost the roller tilt, lost some of the radial inclination, it's shortened. It's got it's highly comminuted with intra-articular elements to it. It's again an unstable injury because of especially because of the level of comminution.
Yes, the comminution is going to be. So you're going to manage that differently to how Mr. Smith's managed it, or the same?
Probably the same initially. I'll still see if I could obtain a good close reduction and then get a check X-ray and see what the quality of the reduction was.
So let's say you reduce it and it's perfectly reduced. You're going to treat that conservatively.
It's not unreasonable to, but you've got to bear in mind that it's going to be more unstable than the previous one, and therefore you do have to monitor it closely in the outpatient clinic.
If you're going to manage that conservatively, I suspect that you've got to have a move into your house and set up an X-ray machine 24 hours a day. That is not going to stay where you put it. Is it?
They definitely won't stay exactly.
So you've got to be careful about sort of answering questions and sort of saying, well, okay, I don't want to commit to anything too early. But I think you've got to be, if you're going to treat that conservatively, that's going to come back and it's going to have shifted.
The only thing I would say is I do think you get a really good reduction. You are entitled to watch it. You're only going to be at 1 week. I think there's a lot of merit in waiting till a week to get less swollen and get so.
But that's a different argument that was made there. The argument that was made there is I'm going to watch it because it might be all right. You're going to watch it because you're thinking the operations are probably going to be easier in a week.
Well, I mean, it might still be all right. There's a small chance. I think it's a very low chance. But if that were mine and it reduced really nicely, I'm not going to want to poke around and mess on it.
Yeah, I accept that. But let's assume that someone's young and useful to society rather than biasing the whole thing by thinking it's the professor.
I was just going to say, I guess like Tony always said, it was you've got to consider the characteristics of the patient, characteristics of the fracture.
Good.
So we all agree that the characteristics of the fracture are pretty unstable, but if it's 90-something-year-old with loads of mobility, etc., then be less inclined to do.
Yeah, good argument. It's very difficult, distal radius, for this reason. And we debate them all the time. And there is no right or wrong answer, and everyone's trying to find the right answer. And so you need to make a plan, if you're thinking for the exam, about how you're going to handle these injuries. How you're going to handle first the description, how you're going to say whether it's unstable or not unstable, and then how you're going to plan your management. So what are your management options apart from conservative for this distal radius? Anyone? Okay. What type of plate? Okay, so let's say that first. if we're devil's in the detail with this exam, and it's about, it's a volar locking plate. Okay, that's an option, isn't it? Anything else?
Dorsal bridging plate.
Dorsal bridging plate
Or an X-fix.
or an X-fix. All of them are reasonable if you so wish to treat them like that.
You just need to be aware there are people, I'm not sure anyone around here, but some people do use these sort of multi-plate systems, a bit on the side, a bit on the back, a bit on the front, a bit everywhere, and they think they're better. I don't know anyone around here who's doing that, but there are.
I think Mr. Loudon does it.
Sorry?
I think Mr. Loudon might do.
Right, yeah, he's a good surgeon, so there are different ways of doing it.
Rui does a little bit as well.
Mr. Field does it for certain cases.
What, on the one that he does each year? Lost my way a second. What could you do for this that no one's asked for? Investigation-wise. So CT's become quite popular. So, I mean, I tend not to order many CTs. What I don't quite understand is you do a CT scan and then you fix it with an X-ray. And you go, oh, look, all these fragments, and then you do an operation and you think, wow, it looks all right on the X-ray, we'll have to accept that. But CT is becoming very popular. So you've got to be aware. I think if you've got a highly comminuted distal radial fracture, you should be mentioning the role of CT to give you some more information.
And I think it'll tell you it's highly comminuted.
If you're going to use a dorsal bridging plate, you'd like to try and get CT to almost justify that by looking past the intramuscular. Does that help in justifying the decision to use the dorsal bridging plate?
No, I don't think it does. I think if it's so comminuted, then I'm just not sure CT helps that much. And a part of that's having done quite a few of them, like a lot of our colleagues will arrange them, a lot of people will do them, and you look at them, and then you critically work out whether it's really changed your decision or helped your decision making.
What do the hand and wrist surgeons say that the CT is useful for them? Because
some people do, yeah. For me, I just haven't found it has. But that may be just my failing. What are your options with this one? Who wants to treat it conservatively? Who thinks we can? Yeah, good.
Looking at that, we've got changes in faces of thumb, so we're looking around the patient. It could be a question as to how old they are, what their level of function is, dominance of hand, cognitive function. If this is a demented 99-year-old, look at such a cracking, carry on.
Okay. So do you think you can improve that fracture with a manipulation and a plaster?
Control the length.
Do you think you can control the length? What you need to accept with these sort of injuries is that that's the position that you've got to accept it healing in if you're going to treat it conservatively. And as you say, if it's a demented 99-year-old, you might accept that. But you're not going to control that very well in a plaster, so you've got to accept that it's going to go back. And you've got to be aware of that from the beginning. We see a lot of people go, oh, as you say, we'll reduce it and we'll see how you get on. But you know it's going to go back. And that might still be your decision, but you've got to be prepared for that when you accept it. I think too many people go, oh, we'll see if it's all right, we'll see if it's all right, and in 3 weeks it's not all right, and then have some big debate. And you think, well, you knew that wasn't going to happen. It was going to happen at the start.
But would you not at least try to reduce it? I know you're not going to be able to.
So why am I going to reduce that fracture?
Median nerve.
Yeah, so I'm going to do it to protect soft tissues. And I might do it to buy some time until someone else comes. Unfortunately, I can't wait until someone else comes, but other people can.
is that the sort of pattern X-fix is a good option?
It's a possibility. I don't like X-fixes, but that doesn't mean it's not a possibility. Alternative to that?
Bridging plate.
A dorsal bridging plate, which I think is becoming more and more popular.
Yeah, I think the X-fix is very much out of fashion. So I think you're going to talk about that in the exam. You've got to say, That's what you've got to explain what your experience of it, what the downsides and all the rest of it. And you should never just put on an X-Fix. You've always got to do an X-Fix and KY, an X-Fix and bone graft, but never just an X-Fix. I think that was lessons learned 20 years ago.
These aren't the best X-rays in the world. With some dorsal bridging plate that I did not so long ago, I don't think I've done it very well. In that we haven't really regained radial inclination.
Is that not a failing of the dorsal bridging plate, that you can't?
So, interesting enough, that doesn't show very well. That's on the middle metacarpal. I regret that now. I wish I put it on the index metacarpal. I think I would have got a little bit more round. That fragment's probably loose. By that I mean the radial style, I think there's some comminution under the plate. So that's probably a floating fragment, so it might not have improved it with that. And I wish I bent the plate as well before I put it on, because I think I would have got a bit more volar tilt, or at least got one back to neutral. So you can do that if you pre-bend the plate, because it is essentially an internal external fixator.
I think these work surprisingly well. I'm surprised how well they work. I think the key is, though, you've got to declare this early in theatre. What you don't want to do is go and bowl a plate and then, oh God, and then close that up and then put it on the back. Because then you open the back and the front, and then it's just awful. You either go, you're going to bowl a plate it and you're going to be good enough to fix it, or you're going to go, I'm really not sure, I'll play safe. I'm surprised how well these do, considering how convoluted they often are.
In your experience at Bath, how long do you tend to leave these on for?
8 weeks.
8 weeks.
And I wonder if that's too long. I wonder if I should be reducing that to 6 weeks. The problem often is that they are highly comminuted, so you sort of think, I want to give them a little bit extra to get solid. So 8 weeks is what we would normally do.
Does that vary depending on your patient and bone stock as well as the injury, or is it just that they're all going to be nasty injuries, therefore that's a reasonable period? So.
And I think with something like that, you could easily put some wires in through the stylo if you just wanted some wires in for a stylo for a few weeks just to give a bit of extra stability.
Mr. Smith was very keen to do that, and I had to stop him. In the end, I had to give him a wire just to play with. Take his mind off trying to stick it into the bone. And we did look at that. We gave due consideration, didn't we, Mr. Smith? Yeah, I say you were keen. My feeling was I don't think we could improve that. Maybe I'm wrong. It's not my finest bit of work. I'm happy to admit that. I put that up there, so I know you all know this. I put this up in my medical student talk, so I'm confident. Well, I was confident up until the FCR question. Just then worry a little. But you've got to know this when you turn up to the exam. You all think, oh, I know this. This is straightforward. And then someone asks you on the spot to work it out, and then you start going, I don't quite know, what level do I put it in? Got to know this inside out. They're going to expect you in the exam to go and do it. The other then advantage is that you can bring it up. You can go, well, I've told about inclination, I've told about volar tilt, and I know how to measure it. So I'm absolutely clear, this is my take on it. This is not what I necessarily think you should say or do. You've got to make your own decisions about how you're going to approach the distal radius. What I will say to you is do not dismiss draft. There's people out there that don't believe in draft. I still think it's the best bit of evidence that's out there at this moment in time on the subject. You might not agree with it or not. That's your choice. You've got to know it inside out. I think the Fully Love editorial in the, was it in the Hand Journal?
No, it's JJ.
JJ. I thought it was a little harsh, but it's worth reading. It's quite a good synopsis of it. If you're going to turn up in the exam, they're going to ask you about draft if you have a distal radius. And my opinion is that if I take them to theatre, if the fracture reduces, I wire it. If it doesn't, I'm looking to plate it.
That's spike draft 2.
Sorry?
That's spike draft 2 at the moment before you wait until.
Well, we'll wait and see, won't we? We'll wait and see. I don't think that I'm going to get to the point where I'm going to manage them conservatively, which is what it's looking at. I think I've already got my group I'm managing conservatively. I'm not sure it's going to change my mind.
Yeah, I mean, draft 2 not going to be out for a while.
No. But it's looking at, if you can reduce it in theatre, then you can randomise and you could potentially keep them.
If you've gone to theatre, I've seen too many of them just been, oh, it'll be all right, it's reduced okay in theatre, and they don't know. You're not going to be able to reduce it outside theatre, you should fix it in theatre.
I generally don't do an MUA in theatre. I think if I'm going to take them to theatre and have an anaesthetic, they get some metal work put in. I'm not going to say always, and then sometimes you might do a distal radius when you're doing a hemi or a DHS. But if you are specifically going to go and you've gone to the effort of giving them anaesthetic, if you think you can reduce it and it's so comminuted you can only put a plaster on it, then what's the point of doing that in the first place? Would be my argument.
Very anecdotally, I've seen quite a few actually in the last 6 months or so that was randomised to cast in theatre.
Oh, that's a different question. If you're part of a trial, that's a completely different question.
No, as in just, it's not like my question was as it stands, but I mean, as in like, following draft 2, what do you think you might do? Or giving draft 2?
Well, it might throw something up. We might start treating them more conservatively. I suspect that we'll just be able to justify what we're already doing. Yeah. Is my feeling.
So, Alex, how many wires, what size, and what configuration? Any thoughts?
So I think you should have a minimum of 3 wires. I don't think you can ever have less than 3. And I use 1.6mm K wire.
And what's your preferred 2 style?
Yes. And if my styloid is particularly awkward, I'll go for 2 in the styloid.
And Kapanji, or not?
Yes, I do. That's my preferred technique.
And you can leave that wire in, or you can actually put another wire?
I can pad you and leave that in, and then I will put an additional wire.
And how long do you keep your wires in for? 4, 5?
You tell me. 4 weeks. How long you want to take them out? I think that's too early, but that's my opinion. There's no right answer. What you've got to do for the exam is you've got to be clear. So why don't you say, I take the wires out 4 to 6 weeks? Is it 4 weeks? Is it 6 weeks? Or is it in between? And that's really important. I'm going to take them out 5 weeks. So I look at them at 5 weeks, and if it's a really comminuted fracture, or I'm thinking this wasn't held very well, I might say, well, look, the wire sites look great. Let's give you another week.
Once you've taken them out of cast, do you put them back in cast for another week, or you?
Once I've taken the wires out, occasionally, but generally not.
What's your indication for putting them back into cast?
If it was particularly unstable,
Cowardice in the face of the enemy.
yeah. or Mr. Smith's done the operation, and then at 4 weeks I have to pick up the pieces. And that happens a lot. Is that is that other people do operations and then you've got to then do the follow-up. Mr. Smith's been in Bath forever. Come on, what do you see there?
A lot of wrists.
For reassurance, it's
So-
all the same wrist,
Same
just
wrist.
lots of different pictures.
So we have 5 images suggesting that they are looking at a scaphoid injury.
But what are the 5 scaphoid views on your breast?
AP.
No, it's not.
Good start.
PA. Semi-pronation.
Anyone know?
Lateral view.
You probably don't know, but you ought to at least know. I think you should really have these days a minimum of 4. You should probably be going for 5. The SWIFT trial's got 5, one of which is the zit view. I can remember exactly. But I think it's probably something you should at least have some handle on. Because I think if you look for you look at scaphoid views, and I've seen this, you've got 4 views about which one is the same as one of the others. That's not acceptable, and you need to send them back. If you miss a fracture or somebody showed you a fracture and you had inaccurate views, that's going to be your responsibility. Anyway, sorry.
This side of the room is going to liken us to the 4 scaphoid views. They were chomping at the bit, I could see them. Mr. Tucker was particularly keen.
Well, the PA view, a lateral view, and then an on deviation. And then the fourth one, I think, is it with a slight, just with slight, is it you effectively are what's called low view for
Yeah, well, I always used to do the older deviation. I used to have one supinated view and one pronated view. So there are two obliques, one in pronation and one supinated, but not in full. So that, I used to remember doing 30 in each, because there's so many different views you can do. So I just wanted to make it easy to remember. Because for the exam, those are the sorts of things that you're going to get asked at the beginning. And then you're thinking, oh, it's all gone terribly wrong. I don't even know how to x-ray this very straightforward injury. So we stopped you in your moment of glory. So
there's a fracture through the waist of the scaphoid. It doesn't appear displaced.
what have you based that opinion on? Your own extensive experience?
I'm just looking at the alignment of the cortices. Although there is a fracture line, then it's not grossly angulated.
What did Tim Davis say about scaphoid fracture wastes, if you could see them? That's what he says. And yet, lots of us say, oh, it's an undisplaced scaphoid waist fracture. He said, if you can see it, it must be displaced at least 2 millimetres.
Yeah, I would say I hate the term undisplaced, because I don't think you can see an undisplaced fracture except on an MRI scan. Because if you can see a line, it's displaced. And I just think we should try to cut out some of this very loose talking we do, like anatomical reductions, undisplaced fractures, because they don't exist. So I think you're much better off about a minimally displaced fracture.
Okay, so we've got a minimally displaced scaphoid fracture. Chris, how are you going to manage that?
They'd have to assess the patient to see what the function is. If they're a high functioning athlete, they might need to get back to sport quicker, or they have a career such as being a builder that they can't be off work for a long time if they have a non-union, have to have further surgery.
Okay.
In terms of this, you discuss the options with them. If it's only minimally spaced, then you treat that normatively for 8 weeks in a cast.
What type of cast?
So there's no evidence to show there's a difference between a scaphoid cast or a below elbow neutral cast, so the latter I would choose.
Okay. And you want it in there for 8 weeks. What are you going to do at 8 weeks?
So I'd take off the cast, assess the patient for any pain, and also get repeat radiographs as well to confirm it's united.
Okay. So do you think the radiographs are going to show you whether it's healed or not at 8 weeks?
I think it will probably show signs of healing at the fracture.
So what signs are you going to look at in this scaphoid that is healed?
So you can see if there's widening of the area where the fracture was to show there's being bone absorption before you're then getting, if you've got osteoclast activity.
That's going to show you it's not healing, isn't it?
It'll show you that it's midway through. But it hasn't actually dissipated.
So what's going to tell you that the scaphoid's united? That the gap's got bigger?
If there's no change in the fracture gap.
So if it looks exactly the same, you think that's a sign it's healing?
I think it's more if it's non-tender when you examine the patient as well.
Oh, okay.
You can tell.
Feel like we've just suddenly taken a left turn. Do we want to go back to the clinical examination?
Okay. Mostly based on clinical examination. If they were still tender, then you might think about having further imaging. We weren't convinced it was healing.
And I think that's where we're moving towards, is the reality is you can't tell on an x-ray at 8 weeks whether it's healed or not. We all do these x-rays and we all say, oh, it looks like it's healed or not, but I think it's really difficult. And so the vogue now is doing CT scans, because the CT scan can tell you if it's healed or not. So what are you going to do at 8 weeks if it's non-tender and you can still see the fracture?
You wouldn't, if it's non-tender, then you wouldn't necessarily place the person back into plastic cast. I think you would potentially give them a spin to start off with and just gently build up the activities and then follow them back again to check that it hadn't become
When?
painful.
When are you going to see them again?
I think you would see them at a reasonable timescale in the future, such as another 6 weeks, but advise if it became painful in the meantime to return to your next clinic.
So you're going to, and what are you going to allow them to do in that 6 weeks? You're going to go back to work?
So gentle activities, but you wouldn't allow any contact
Gentle
sporting
activities.
data activities such as writing, using a computer. You wouldn't let them do any contact sporting activities or any heavy building type work if that was their profession.
What about driving?
If they're comfortable and safe to drive, then they could drive. In terms of insurance.
It's a reasonable. It's not. There's no right or wrong answer to any of this. This is what you see every day when you're in clinic and these patients ask you the question. I think in another 10 years we'll be CTing them all, and I think that will be the sort of standard investigation for a scaphoid. That may be at 6 weeks to see whether it's healed or not. It may be at 8. We've already got our radiologists are keen to CT more and more. We've got some new double scanner.
So if you CT'd all your patients at say 8 weeks and have less than 50% say cortical bridging, so would you then immobilise them again and then re-CT in another 8 weeks? Or?
So I think if it was 8 weeks and you CT'd it and it showed any bridging, I would be happy that they could be in a splint and starting to build up some activity at 8 weeks, because it's started to heal, it will heal. And that's why I think that's going to be helpful, these CTs, is it on the way to healing or is there nothing? Because if there's nothing at 8 weeks, what are you going to do? You're going to fix it.
How often do you see ones who are non-tender on clinical examination but are not healing? So how often is your clinical examination inaccurate at picking them up?
Oh, his is brilliant.
I find it difficult to argue with that. We've had a couple. We had that chap that was completely non-tender.
Yeah, 10 days.
Injury.
Scaphoid fracture, 10 days, completely non-tender, and both of our detailed examinations. It happens.
So rarely though.
But if you've got a fibrous non-union that's not painful, why would you then fix it?
Good question. Because there's no clear-cut answer to that. If it's non-painful and stable, do you need to fix it?
Yeah, well, I mean, I wouldn't, because why would you?
Yeah, and I think it's I mean, you're not going to know that at 3 months, so there's still going to be some tenderness. But if someone comes to you in a year or two, clearly not united, they're not collapsed and they're non-tender and it's not progressing, there isn't cyst formation, I think you'd be entitled to suggest that they watch and wait. And then you keep an eye. I think you want to see in case it was collapsing, and if it was, then you might change your mind. And it depends how old they are. Once you've got to my age, by the time you got arthritis, so late doesn't really matter. And if they're 21, it's going to matter more. These things aren't absolute, and that's what makes it both interesting and challenging. So, yeah, you don't have to fix, and you need to be able to justify. You need to explain why to yourself, to the patient. Yeah.
But if we CT at 8 weeks, if we're going to CT at 8 weeks routinely,
you can't tell. The thing is, at 8 weeks, you know they're going to be painless in a year. You can't tell that. This is your problem. Almost everything we're doing is crystal ball guessing what's going to happen in 2 years' time. And sometimes we think we know distal radiofracture or scaphoids, and then we base on that. But it may be that's the person who's going to have a painless fibrous union. But the trouble is, if you wait to find that one person in 100, there are people who've got non-unions you could have treated earlier, so you just can't go down that route.
Do you use CT or MRI for if you're suspicious as an occult scaphoid fracture?
Which would you recommend?
I think I've worked in units that use both. Suppose
What,
MRI.
CT and MRI?
No, usually one or the other.
Okay.
I suppose some departments argue that MRI would be more sensitive
To what?
to diagnose occult fractures.
I'm not sure the evidence is there for that. Which is better at picking up the fractures? Which investigation?
What was wrong?
CT for picking up the fractures, but what's MRI good at picking up? And Yeah, so other injuries that might not be the scaphoid. So that often the argument for the MRI is it will pick up the fractures, but if there's no fracture, it will pick up other injuries. But most people would agree that if you're just purely focused on scaphoid fractures, the better one is a CT scan.
That's what's your limit for the percutaneous fixation? Is that a couple of weeks, or how long? If it's still minimally spaced but not hitting on a CT, how long can you do percutaneous fixation for?
So, in terms of percutaneous fixation, I don't think there's strong evidence about what you can and can't do. My personal opinion is I'd do it up to 3 months. And that's why I want 8 weeks. I want to know whether it's healing or not. If it's not healing, then I want to get my screw in the next 4 weeks.
I think that's reasonable, and I will do it much later. Because my argument is, I think there's no evidence that reduction makes any difference. I think it's a much smaller operation, and what I'm going to do much more now is fixing, just putting a screw across it. It's a reasonable position. And then I get a CT early, I would, see them at 6-8 weeks. I think you can often get a pretty good idea whether they're uniting or not. If the X-ray looks really good and they're pretty comfortable, I'm relaxed. If any doubt, get a CT. Then if they're not uniting, then I can easily open them up or re-screw fixation. I think it's so much less than open fixation. So that's what I would want done for me, and I tend to do that more. But I suspect I'm going to have some more non-unions than Alex, more second operations, but I suspect overall more people with fewer complications. That's my view on it. But I don't think there's a right answer.
What's key, I think, is making the decision early that it's not healing, and not leaving them and leaving them and leaving them.
What about the ones that have been slightly neglected? So they've kind of been seen A&E, missed, and then represented, say, 2 months later, still tender. So you're seeing them, they've had no treatment for 2 months. Is that you missed the boat with?
So what's the evidence?
Well, imagine none.
There's quite a bit of evidence on this about, so what's the key numbers for a scaphoid in terms of non-treatment? So it's 4 weeks, isn't it? It's the key number. If they haven't been treated with it within 4 weeks, then the non-union numbers go up massively. I can't quote them to you. I don't know them off the top of my head. Tim Davis did the work.
No, it's Langhoff and Anderson.
Well, there you go. I don't even know who did the work.
It's not a great paper, but they do show that it starts increasing substantially.
So that is the key. So in terms of an exam, if you're going to it, that's what they're going to be before 4 weeks or after 4 weeks. And then that. So if it's after 4 weeks and no treatment, then I would favour operative intervention in whatever form that comes. So that might still becoming a percutaneous operation because you've looked at it, it's completely undisplaced. Or it may come in the form of open reduction and coring out in the middle and package and grafted. But be very wary about treating a scaphoid conservatively that has been not treated for the first 4 weeks.
Yeah, I think it would be reasonable to go for a plaster maybe for another 4 weeks, get them, see them at 8, get a CT or something, and really know. And if you didn't, then you could fix it. And some of them will unite. But yeah, once you're beyond 4 weeks of no treatment, they've often moved quite a lot. You often see a cyst, you're thinking that's not going to heal. Probably thinking.
Okay, so the splint counts as treatment.
Yes. If worn properly. And then that's open to a bit of negotiation. Which is why, it's entirely reasonable if you're not sure in the clinic and you're treating someone, I don't know if it's a scaphoid or not, keep them in a splint because you're treating them. Not everyone has to go into a plaster.
Why do you treat anyone in the plaster then?
Sorry?
Why do you treat anyone in the plaster then?
Well, because
it's reasonable as a normal to.
I think because you've got to be sensible and you've got to use it and you've got to use it properly. And you're right. I think I could treat myself in a splint because I'd be sensible about it. He says. But you're out there doing it. You don't trust anyone you meet. Especially you guys working in Bristol, it must be even worse. At least we're in Bath, which is quite nice. You're not going to well, they're not going to do what I say at all. What do we see there on this side of the room? We won't go through the individual scaphoid views again. See Mr. Tucker at the end if you want a full explanation. Cyst formation?
There is a lucency just distal to what I think I can see.
Okay. So this is an acute proximal pole fracture, so I suspect not a cyst or an area of lucency. I think it's just a reflection of the amount of displacement. But it's pretty obvious, all of you can see it, so it's got to be displaced if you can all see it. So how do we want to manage this? And how are you going to fix it?
A dual approach, if it's undisplaced, that's graceful.
Okay. I think there's less debate about this. Proximal poles need fixing. If I had a proximal pole, I'd want it fixed. What's the union rate of a proximal pole if treated conservatively, assuming that it's treated properly in a reasonable time frame, etc., etc.? What's you going to tell your patients that if I treat this in a plaster, the chances of it healing are 20%. So you think 80% won't heal if you treat it conservatively? We in agreement with that? Do you want to go higher or lower? This is when I bring out the cards. Yeah, we can do a bit of play your cards right.
Depends how proximal it is.
Depends how proximal.
Okay, what's the definition of a proximal pole fracture? Current acceptable.
I thought the divided into proximal fifth or proximal third. Wow.
Well, they're different. You've got to choose one or the other.
Okay, a proximal fifth, I suppose.
Yeah, so the proximal 20% now, they reckon is the proximal pole rather than the proximal third. So anything in there is going to be small.
Yeah.
So based on that definition, does everyone think it's 20% union rate?
Probably even lower than that.
Lower.
Lower?
It was high. 40% union, 60% non-union.
Is it not?
I'm a bit worried about all these people out there giving me information. If I move from cubicle to cubicle, that'd be a phenomenal variation. Can I see that one, please? I think it's over 50% are going to heal if you treat it conservatively. The problem is that 40 or 45% aren't going to heal. That's an unacceptable non-union rate in people's eyes. I always learn 60-40. 60 will heal and 40 won't. And that's what I tell patients. The problem you've got is that the patients will hear 60% healing and think they've got a good chance because they're not quite as educated as they think they are. Similar to this group in a way. So, what have I got here? I think. Yeah, we can do that. I'll gloss over the rest of the wrist and. Okay. What do you see there? So I didn't quite hear that
That
clearly.
was apex folder angulated proximal phalanx fracture. Trying to work out which finger that is.
Have you based that on the fact that there's two on the outside? Because I do see some patients from Wales, so that's not always a reliable way. So how do we want to treat that one? Now I've had it. It's going to be easy. You've already been told. So you want to treat it conservatively?
Well, you want to assess the patient, assess rotation, assess neurovascular status, whether or not it's open, and then based on that, you want to try and reduce and align it better, and hold it with a splint for a few weeks, or 2 weeks, 3 weeks, to make sure that it's stable, and then you can get it moving earlier.
So what's the challenging part of your plan that you've made? Do you think so? Do you think it's going to be difficult to reduce?
I think probably you can probably get a good reduction initially, but then maintaining that reduction will be challenging.
Okay, so the challenging bit is the immobilisation, isn't it? And I think that's your difficulties. I think they're quite easy to reduce, but can you hold them reduced? And so, so Prof mentioned that you can do a Belsky wiring, so I put some pictures of, has everyone heard of Belsky wiring before? Or not? So you can do it by drilling through the metacarpal head, and then it goes down the line and holds it. So they don't move their MCP joint for 6 weeks, rather wise or 5 weeks. So our physios don't like it. I quite liked it when I started because it was quite an easy operation. And you pick the ones you think are quite easy, and I could do it. So I thought, oh, this is a good technique. I don't really do it anymore. I don't really like it because they do get very, very stiff, having not moved. So I've done one for ages.
No, I agree. I used to do more. I think 2 things. I'd say don't overflex the MP joint. Everybody don't like that. And you've got to then move the IP joints quickly. You mobilise the wire and plaster and bend it, but you've got to move these, otherwise they stick at under the A2 pulley. They get flexible adherence. You can slide it up the side, which is another way that you get a bit more movement. It is useful in some patients, but it's not often done.
I wanted to get to the PIP joint. I think I went the PIP joint now. What do you see there, Selena?
Maybe lateral part of the right hand, injury of the proximal end of the middle phalanx of the right ring finger. There's fracture which is intra-articular and displaced.
Undisplaced, did you say?
No, displaced.
Displaced. What else is going on? What's also?
It's causing some subluxation of the joint.
Some dorsal subluxation, isn't there? So what's the first thing, or what's the most important thing you want to know? Someone said it. Sorry? No, I don't care about that. What do we care about? Yeah, whether it's organised or tilts. That's what matters. Okay. So this is quite interesting because he did. So when we got him to flex in theatre, he pivoted on that point at all, completely. So he was. If we'd done nothing, then you know he's going to do badly. You've been told that. But if he glided round, then you probably could have done what? Yeah. So got them going early and said, let's move it, but he didn't. So we're now in a position where he's pivoting. So what's our options?
Can I just say one thing? Though I think that's all correct, I don't think we've proven that yet, and I think that's a bit too cutting edge for the exam. So I think you can use it for the diag joint. We've written the paper, it's out there, and the paper won't have read it, but you can talk about it. But I think for the PIP joint, you've got to be careful. If you're going to talk about that, you've got to say one unit, you've seen it, and you're aware of it, but the more conventional treatment is or something, or just stick to the conventional stuff in the exam. But I think going forward, it's something for patients.
So what are your options?
Dorsal blocking or
Okay. So an open reduction. So what? Okay. So what you're going to do is for open reduction, if you're going to do it.
So the fragment is lower, I mean, I can't really see exactly how big that fragment is, but it looks fairly, I don't know if, I can't see if it's comminuted or not, but assuming it's not comminuted, and it's just 50% of the joint surface, you feel that you could possibly fix that back on and hold it with some wires. You could approach it permanently, reduce it, and hold it with some screws.
As you say it out loud, does it feel like it's a good answer?
So, as I say it out loud, I know that it's full of complications. It's not an easy procedure. It's not something that I would do, but definitely have been told that that is an option.
Okay. So if we want to go all the way back, what's the principles of managing fractures?
To align them and to get good function.
So that's your aim. What's your principles for managing fractures? Your three basic principles are?
To reduce.
Yeah.
Stabilize.
Yeah.
Yeah.
Yes. So reduce, hold and move. What is your priority with the PIP joint? Because we always want to be in the middle of that Venn diagram. That's the ideal, but often we're not. Which circle do you want to be into if you have to with the PIP joint?
You want to get them moving.
Yeah. So that's the key with the PIP joint. We know only yesterday did Mr. Smith sit down in his chair with a sigh, say, these PIP joints, they're difficult. They do stick out. Don't they? So you want to get them moving. So is your plan going to get that PIP joint moving? Opening it up, fixing it?
No, I mean you could get it moving.
Yeah, yeah, you could.
So yes, you could get it moving, and therefore.
But you made a wound over that joint. What's that going to do?
Yeah, they'll stiffen up, but if you get it moving aggressively, then you
aggressively.
Yeah. But if you stick it,
as only a South African can say. What are you going to do? Sort of march him up and down the corridor?
Have you seen the show?
Well, I've seen that. I've seen that. And then every so often they get shoved under the tap. He comes back out and says, "No more." So yeah, I suppose that's the definition of aggressive mobilisation.
Waterboarding.
Seems to have taken a nasty turn.
But if you put a blocking wire in, you're not going to move that joint either. So.
Yeah,
I'm arguing
an
opinion that I don't necessarily believe in, but I have definitely.
But you said it.
I know. So I've definitely been told that is what you need to do in certain circumstances, is to fix them. So, but I.
You're right. There are people who fix that, and they would put a plate on the front. I mean, that there's comminution. That further fragment couldn't be that shape and displaced that amount without some comminution to do it. But people would do, and the zealots who believe in open reduction of this will do it. Do a shotgun approach, open it up, lift all the flex tins out, put a plate on, get them going. They don't horribly swollen, but the X-rays can look quite nice. But I think the research evidence suggests that in the good studies they do as well as probably anything else, but they tend to end up stiffer. And when they get complications, boy, they're complicated. And that's your problem. So you're doing a lot, but probably no great gain, but a nice looking extra.
I mean, every option's available. There's no right or wrong answer. I think this one we could have dorsal blocking wire on. And I'm not overly happy with the position that that's achieved, in the sense that it still doesn't quite look right, that joint.
And what effectively the dorsal blocking wire, and I didn't really come into any details, what that is trying to do is to convert pivoting into gliding. So you push the base of the middle phalanx boldly enough that it will now glide. And that's certainly gliding more than I suspect it was. Probably not bad. And mostly I don't think the dorsal blocking wire works these days, because I think that if they pivot, they'll pivot enough. I mean, if they glide, they'll glide enough. And if they pivot, I think it's very difficult to convert them into gliding with a dorsal blocking wire, unless you push them a long way forwards. So increasingly, they've reported a good series at the end of the 90s from Nottingham. I think that actually if you take out the gliders, the pivoters don't do well with it. That's my current feeling. But that's unproven.
Why not do a dynamic X-fix? Because then you can get them moving straight away. You've got legal antistaxis to hopefully get some secondary conference, and you kind of avoid the stiffening phenomenon as well.
Yes, I mean, it's a reasonable thing to say. You could have put a dynamic X-fix on it. Sorry? Well, yeah, they can be a bit uncomfortable. The problem you've got with a dynamic X-fix is that you only know after you've done it whether the patient can tolerate it. And that's the bit I wrestle with. Is that some patients do really well with it because they get it going in a minute. I remember doing it on anaesthetist when I was a fellow, and every morning he'd come in and inject his finger with local anaesthetic and spend an hour moving it. He got a good result, but that's not what everybody else can get to do. And then you get the person who just comes and goes, and you can tell, oh, I can't even look at it, doctor. And then you're thinking, oh, we're on a hiding to nothing here. So that's my problem with X-fixes. I think that this wouldn't be a bad. I think it feels like it might be a little bit of an overkill for an injury like this, but it's a very reasonable thing to do.
Yeah, I think that, I mean, it's my go-to treatment. I'm offering for these, but some patients don't tolerate it well. It was Ian Loudon who described blocking them in clinic, putting local anaesthetic in clinic and getting them going. And I think, and I'm not a fan of it anyway, it's one of the few times I think you can get them going. It does give them a bit more confidence, and it does have a getting going. And you could probably do that weekly for a few weeks. I have done that once or twice, just to help encourage them.
The other thing I would say is you should always put them in under local anaesthetic so that you can demonstrate to the patient and show them that it moves. When I started, a lot of them would just come under GA. And we're doing a lot more of the local anyway as a specialty. But I implore you to put all of these in under local so that you can show the patient, look, you can move, you can make a fist, you've got to work at getting that every day until I see you next.
What size wide do you tend to use? Just a 1 mil wide? Or?
For the X-fix, for either, I'd use a 1.1. The 0.9 wires for the X-fix are too flimsy. And I think this was a demonstration of the X-fix. For those of you who don't know it, have you seen it? Has everyone seen this? Yes, no?
Yeah.
So there's lots of dynamic X-fixes out there. You can buy them off the shelf and sort of have them ready-made. This is one that you can manufacture yourself from 2 wires.
And you see, again, that's converted a non-gliding situation into a gliding situation. So that, I think, is the key to the treatment of this. That's what you're trying to do. And it sort of doesn't matter, you could put a plate on, whatever. As long as you get them into gliding, they should do well. Not always, but that's what you're aiming. They're pivoting, they will do badly.
I think if you open these up, it's a disaster. If you are maybe doing an operation that makes a cut around the joint, it's an absolute, and I say that from personal experience, I've done it. The stiffness is just phenomenal, and you can't get back from that. You need to do a treatment that allows you to move it, would be my absolute priority. Leave it there, you look like you're all flagging now. Yeah, what's the fine? Any questions, anything that?
I would say that, you know, we've given this talk 5 years ago, it's been a bit different, and it'll be a bit different in 5 years' time. I mean, it is evolving, and there are all sorts of new treatments. What's becoming a bit more popular is putting out an intramedullary screw into both metacarpal shaft or proximal phalanx fractures through the head of the joint. It's only a small surface area. Now, it's a bit more popular in Europe where they get paid more for it. But that probably will start to come in for some of these fractures. That's an alternative technique. But it is gonna move on. So don't feel that this is the definitive answer on everything. Be aware that things change and move on.
The key for the exam is that there is no right answer, but you've got to justify what you say. Don't get caught up in thinking I've got to manage all of these this certain way. Lots of people turn up and get a VIP joint and think they've got to put that external fixator on with the person sitting opposite, it's the person that wrote the paper. So, but you don't have to do that. Just, whatever you say, this is what I want to do and what I want to achieve. It's a bit like you saying, I'm going to do open reduction. You don't believe you want to do that. I know you don't believe it. So don't allow it to slip over your lips. Great. Thanks, guys. I'd love to get back.
Well, that's amazing.
Yeah, we had some discussion.
I was just pre-warning you.